Hello, my name is Nick, and I would like to welcome you to my series on my BPT journey. This presentation is my own opinion and is not endorsed by any other groups. During my journey, I failed both exams, and it took me 7 years to complete the process. This may sound like the opposite of an endorsement to listen, but through this rocky journey, I had to keep reflecting on and reapproaching this process from numerous angles, which has provided me with what I consider a number of useful insights, which I intend to share so that you may have a smoother journey. This, however, is not a rule book. I simply want you to take the points that help you and incorporate them. This presentation is the sixth in a 10-part series and focuses on the short case of the clinical exam. Sometimes the bell telling you to enter the examination room and to exit the room seem almost the same. You read the stem, adrenaline kicks in, you remember what examination to perform but nothing else, charge towards the patient, complete the exam, rattle off everything you did, and then your mind races to reconstruct it before you have to leave. At the start of your preparation, this is common. The most important thing to counteract it is to remember to breathe when you read the stem and when you enter the room. A single breath at these 2 points can slow down time considerably and will often work to your benefit. Observation is the first step to examining a patient. Not only observing the patient, but observing their surroundings. Just looking at the patient could provide so many clues. A midline sternotomy scar could increase the chance of a valvulopathy and a murmur, plus extra tall, maybe Marfan. So we'll need to clarify and assess for mitral valve prolapse or aortic regurg. The room will also be full of clues. An ankle brace for distal weakness or gloves for vascular compromise of digits. You must make observation a part of your routine because your natural instinct on the day will be rush to start conducting your examination. Beyond the examples here of why the initial clues of observation are vital, I think the most important part is they usually allow your brain to start a train of thought in a direction. Instead of approaching the patient with an overwhelming expanse of possibilities running through your head, you have a hypothesis, which you can prove or disprove as you go. With the cardio patient example, when you get to auscultation, the question isn't which murmur or is there even a murmur? Then the question is instead, is it systolic or diastolic? This has much less of a cognitive load. However, you must remember to remain agile, and if the signs are all negative or unexpected, be ready to pivot. At the start of preparing for the short case, your aim is to conduct all the examinations smoothly and with little thought as possible on what step comes next. Your aim is to be robotic or have the process secured in your reptilian brain. To achieve this, first map out your own process for completing the exam. I recommend starting with reading either Talley and O'Connor or the Stepwise book to get the general overlay. Then, after practicing and receiving feedback, you should make adjustments to optimize timing in your proficiency. Then repetition is key. Practice on everything. Practice on patients, practice on family, study groups, teddy bears, pillows, whatever you can find, it's worth practicing on. Now that you have trained your brain to have an autopilot, the focus is to solve the puzzle of science you've uncovered. The more robotic the technique is, the easier it is for you to process the information given. There are a number of ways to develop this skill of processing. Firstly, seeing patients will help with pattern recognition. Watching others, other trainees, advanced trainees, recorded short cases will also help with this, but can be further enhanced if the person also talks aloud their thought process. So request this if possible. Books like the Clinical Medicine for the MRCP's PACES, Volume 1, has examples of perfect summaries of case presentations and associated discussion, which can also help with recognition and presentation. Though, as it is more likely you will confidently identify a sign rather than a condition, it's possibly more important to learn the differential of possible etiologies for common signs. Talley and O'Connor and the Stepwise book can also assist with this. Personally, I spent a large portion of time studying the differentials of signs, putting them into lists initially, and then later expanding these lists into decision trees, where the branches diverged into potential etiologies based on secondary or supporting signs. This assisted with my direct processing of the information and also my discussion during the short cases. I'm going to do a very basic structure of how you may present a short case. Thank you for letting me examine Mr. X. Note, strongly try to remember the patient's name. It will be written on the prompt on the door. I performed an X exam for investigation of X. My most salient findings were X. My main differential for these findings is X. I will discuss my wider findings and then further elaborate on my diagnosis and differentials. Then you go through your exam findings, starting with the general observation and then methodically and chronologically through what you performed and found. Now, before I move on, I want to impress how easily the rush of adrenaline can make you forget the patient's name and the prompt. Though both are important, so an active effort is needed to remember them. Some people have written them down on a piece of paper when reading the stem. I'm not sure how widely accepted this practice is, and I would not only urge caution, but take care with disposing the pieces of the paper correctly. Body language is also an important part of the presentation. Once you complete your exam, you're expected to turn away from the patient and face the examiners. This is easier said than done because you will have a huge urge to look at the patient while you try to recount your findings, but you shouldn't. Additionally, minimize hand gestures by placing your hands behind your back and make sure to speak as clearly as possible. With your presentation of your findings, you need to adjust your principal diagnosis statement based on your confidence. If you are confident, then list mitral valve prolapse. Less confident, then mitral valve pathology with a systolic murmur, or less confident, systolic murmur. The balance is an important one to strike correctly because being correct and confident can secure a 6, but if you are wrong, can lead to a 3. While being vague may prevent you achieving a 6, but increase your chances of a 4 over 5. This is something that can only be learned with practice and personal experience. The neurological examination is probably where this advice is most important, because it is rare to be certain of the diagnosis, and because of this, it is rarely expected of you by those marking. For a neurological exam, the aim is more localization than diagnosis. So that's stating that you have identified a lower motor neuron picture that is unilateral, distal, and pure sensory, or in other words, a unilateral sensory neuropathy, is often very acceptable starting point before then discussing possible etiologies. This is just for revision later, but demonstrates how I broke down presenting neurological exam findings for assisting me with localization discussion. Once you have finished listing your findings, then you restate your conclusion. Based on these findings, my main diagnosis is X, with the differentials of X. If I had more time, I would complete X. Sometimes, if you're lucky, they may actually let you do this. Next, to investigate the etiology, I would begin with bedside testing of. Then I would request the laboratory and radiology tests. Note, never be so general with the investigations requested. You need to request specific tests and state why you want each of them. Now, you can expand on the structure I've provided by giving brief counter-arguments for the differentials that you give. For example, my main diagnosis is mitral regurgitation. My differential for a systolic murmur is aortic stenosis, but I would have expected the murmur to be louder in the aortic region and to radiate to the carotids. This is also where you talk through your neurological localization. Also, to further elaborate on my point about investigations, an example could be, as I am concerned about infection as the underlying cause, I would request a full blood count looking for raised white cell count. You should expect to be interrupted. It is common to be interrupted during your discussion. Sometimes the examiners just want to clarify something. Often, they are trying to help you by leading you back on track. They want to pass you, so don't disregard their comments. You don't necessarily need to agree, but at the very least, discuss the supporting and contrasting information around their comment. Once when I was a bulldog, I saw a candidate complete a hand examination. His summary was that the diagnosis was rheumatoid arthritis. When asked if it could be anything else, he replied simply no, and the markers struggled to progress the discussion. A different approach would be to say, though arthropathy could be caused by other conditions like osteoarthritis, I would not expect the symmetrical distribution I noted, and therefore think this is less likely. The biggest benefit of this type of response is that it demonstrates critical thinking and also provided the opportunity for examiners to assist further. Understanding this actually took me quite a while to learn. In the start, I wouldn't want to say anything until I was sure, for fear of being penalized. However, this often led me to not saying enough in the short amount of time. Eventually, I realized that the examiners cared more about my thought process than the correct answer, and that by verbalizing and demonstrating my ability to synthesize my findings, I was giving them what they needed to pass me. If you are not uninterrupted, congratulations. This usually means you're on the right track. The next steps in your discussion, after outlining the investigations to determine etiology, is providing tests to confirm diagnosis or assess severity. This will usually prompt interpretation of results if you haven't already done so. Following this, you will be expected to discuss basic management and any other pertinent side effects. If you are reaching these management style questions, your chances of scoring well have increased significantly. For both short cases and long cases, there is a huge commitment to practice in the clinical setting. Unlike the written, be prepared to spend more time in the hospital. In preparation for this, I recommend letting your support systems know and prepare your study group to be efficient. It will be important to agree to a format of doing short case practice together, meeting at a set time, coming with cases, predetermined if any socialization is appropriate, etc. At times, you will feel like you are living in the hospital, so it is important to optimize the study time so that you can spend more free time elsewhere doing non-BPT things with your friends and family. Reflection, again, is a key component to preparing for the short case. Keep a record of the short cases you see. This will allow you to identify gaps, namely which common presentations you are yet to see. Also reflect on your prowess with each type of examination. Continue to seek feedback and observe others to hone this. Remember, some short case examinations are more likely than others. Cardiology and neurology are thought to account for at least 2 of the 4 short cases. But this is not guaranteed, and the more uncommon examinations should not be neglected. If nervousness is affecting your outcomes, then consider hugging the cactus and plan to present to an examiner who is known to be intimidating. On the day, the real examiners will be more receptive, though not overly so. But however, in comparison, you may feel much less nervous. When looking for short cases, it is usually best to ask the advanced trainees and consultants on the team, as well as other trainees. The level of appropriateness will vary. The better cases will come from those who understand the exam more. However, there will definitely be times where any case will do. More important, however, is check if the patient is appropriate with the team and then clarify with the patient if they're willing to participate. As the clinical exam gets closer, some patients will get burnt out, so respect their wishes and make sure to communicate them with a wider group if necessary. All of these resources on the slide are personal recommendations. I want to note that they are not required, and in particular, many people pass without requiring any of them. With respect to how to pass the RACP written and clinical exams by Rouse and Johnson, it covers all the stages of the BPT process and provides many good insights. For Talley and O'Connor's Examination Medicine, a guide to physician training, it provides a good outline and approach for most of the short cases. While Stepwise Clinical Examination Handbook by Mackey covers the other outlines for the short cases not covered by Talley and O'Connor, and sometimes gives guides to alternative approaches as well. Clinical Medicine for the MRCP PACES Volume 1 by Mehta, Iqbal, and Bowman give good examples of textbook cases and also the associated discussion. The CliniPrep app is very useful for practicing short cases on the ward with your study group. And the Sydney CliniPrep courses is a resource that offers 1 or 2 day intensives where you have the chance to practice on exam standard patients and receive quality feedback. This slide is here mainly for completeness, though I would highly recommend owning your own blood pressure cuff, as though one is often in the exam room, struggling to position it and use it will waste valuable time. The clinical exam and preparation for it is stressful. If you find yourself struggling with the content, having time to practice presenting in a coherent manner, or experiencing anxiety, then I recommend reaching out to either your DPE, a psychologist, or public speaking groups like Toastmasters. It is also important to let your support structures know and to always remember that you are way more important than this exam and its outcome. My key point for short case preparation is to take a breath. And then after taking that breath, let the reptilian brain take the lead while the rest of your cerebral cortex processes the signs that you are finding. This is the best way to pass the short case. That concludes my presentation on the short case. Thank you for watching and good luck on your journey.